Pediatrics here at RUHS. Very happy for you to join us today. This is after our summer hiatus for the last couple of months. We're really excited to be bringing you a topic on health disparities. This is fortunately something that is receiving more attention in the last year or two in medicine, and finding ways to identify health disparities and then how to respond to those so that we can aim for health equity. So we're lucky today to have with us Dr. Vikram Kumar and Dr. Geoffrey Leung, and they both have roles where they can help us identify and understand and then address health disparities. And so it'll be really interesting for us to hear about their perspectives on this topic. So I want to ask them a question really quickly. They can, introduce us to their roles and how they view that in line with health disparities, and then share with us what their thoughts are on that. And then we'll go into some subsequent topics in this vein. So we'll start off with Dr. Kumar, or sorry, Dr. Leung.
Thank you, Dr. Vercio. So, I'm a family physician by training. I have served as the ambulatory medical director and currently serve as the public health officer. In terms of disparities, I think it's almost happenstance how Dr. Kumar and I got sort of more deeply involved. But really, if you think about kind of even just the past 18 months of the pandemic, one of the things that it's absolutely highlighted is that, even with something that sounds as simple as, and straightforward as providing vaccines, when you try to make accessible a component of healthcare, you have tremendous variability in uptake, and that complexity is partly related. It gives us insight into existing disparities in our county. For instance, we know that with our Medi-Cal populations, their vaccination rates, are often 20–30% lower. In our communities of color, Latino communities, African American communities, our vaccination rates also tend to be a lot lower. So I think the pandemic has really highlighted kind of the challenges that we have with disparities to an even greater degree than what we already realized beforehand. I'll pass it on to Dr. Kumar.
Thank you, Dr. Vercio. Thank you, Dr. Leung. Good afternoon, everyone. So I'm a pediatrician by training, and my current role is the Chief Health Information Officer for Riverside University Health System. And in that role, I work mostly around health information technology, data analytics, and informatics, and so on. As a natural extrapolation of that, I see my role evolving also to look at some of the disparities by different populations we serve. One of the things that we always strive to do increasingly is to leverage data as much as possible to try to improve outcomes. And when we start looking at outcomes and different cohorts of populations, then automatically some of the background of the patients, such as their race or ethnicity, or maybe their gender or gender identity, their economic status, and so on, automatically come into play. And through a natural progression of that, I think Dr. Leung and I were fortunate to come together with a group of like-minded individuals to look into some of these areas across diversity and inclusion and equity with outcomes and so on.
Thank you, both of you, for giving us a little bit of your thoughts on this topic. Can you tell us a little bit about how the Health Disparities Task Force kind of coalesced here at Riverside, and how other organizations that might be interested in doing something similar could approach this?
And maybe, if I can take a stab at that, and Dr. Leung, feel free to jump in as well. So maybe about a year ago. So historically, to take a step back, even going back to its initiation as a county hospital back in the 1800s, in the late 1800s, the Riverside University system has always been a safety net for populations, underserved populations. And then, especially in the last couple of decades or so, as there's been that shift with healthcare, especially towards pay for performance, increasingly, be it the health plan or the state or even the Center for Medicare and Medicaid Services, have also been focusing not only at improving outcomes, but also decreasing the disparities with those outcomes improvements. So towards that, RUHS has participated in various programs and initiatives to look at specific populations and improve disparities and so on. Through last year, through some of the surges and so on, we at the executive level, there was also conversations that was happening around the need to focus on disparities, to measure what is being done, and to also educate and engage staff as much as possible. And towards that, last fall, we invited departments from across our healthcare system that includes the medical center, clinics, public health, behavioral health, and correctional health to present through a workshop whatever initiatives that they were working on with disparity reduction. And we got close to about 20 different presentations. And through that workshop, the next step was we realized that we needed a small group that needed to deliberate on that, come up with some key strategies. And through that, those conversations, people volunteered their time, people and roles were volunteered, and then we developed what we call the RUHS Equity and Diversity Advocacy Task Force. And broadly, that task force promotes three large strategies. One is to educate and engage. And that includes staff, frontline leadership, staff and training, and so on. The second piece is data-driven improvement. So looking at what data we have, how do we publish it and promote it, and so on. And then the third piece is to help develop partnerships. And the task force itself has cross-representation from multiple areas of RUHS, and it also has representations from staff at different career levels, as well as different backgrounds when it comes to race and ethnicities themselves. So it's a very diverse group, and we meet weekly. And those conversations have, I would like to think, moved us forward to deliberate more on DEI efforts.
Thank you, Dr. Kumar. Dr. Leung, what was your perspective on how the Health Disparities Task Force came together and what other organizations might do as they try to develop a similar initiative?
Yeah, so I think you heard about sort of almost the organic development of the task force within Riverside University Health System. And probably if we're talking about other organizations that may not yet have something set up or structured or system-wide with regard to disparities or diversity or equity or inclusion work, probably the first recommendation we have is, think of ways that you can pull together champions or like-minded individuals. When we had the workshop that Dr. Kumar referred to back in November of last year, where we had nearly a couple dozen presentations of work that was already occurring within the health system. It was really quite surprising at how developed many of our disparities related projects were, but also at the same time, it was surprising how little people knew about the work across different, service lines or branches. And so, we would recommend thinking of a way to start that conversation, to start that brainstorming. And really from that, we just discovered that there was enough momentum and conversation and desire to continue that work that we needed to create a vehicle for that. So that might be one thing to consider. Another thing to consider is, using a formal assessment tool. For instance, you can actually take an organizational assessment tool. There's one through, our Hospitals Association in California, where you can survey people within your organization and see what your readiness or level of maturity is with regard to diversity and inclusion work. And that can give you a starting point, as well as maybe highlight some opportunities for improvement.
Thank you, Dr. Leung. I want to transition a little bit from that, and we can come back to that in a couple of minutes, but because I know you have some graphics to share and cover on the task force, and ask you, Dr. Leung, and then I'll ask you a question as well, Dr. Kumar. Dr. Leung, I'm curious, now that you've been in this public health officer role over the last few months, and as you're starting to become more familiar with some of the situations in public health beyond COVID and the health disparities related to COVID, what you see as kind of the long-term public health issues and that would relate to health disparities. So whether it's access to care or whether it's differences in the care that's provided, and we know those there's a broad number of differences in the literature as far as what can be for health disparities, anything from even potentially amputations for diabetic foot ulcers and things like that, to pain medications for children with appendectomies based on race or ethnicity. And so I guess I'm curious, what you've identified so far in your time as public health officer, so that we can kind of think about that across our region.
Yeah. So I think one of the things that's interesting is, from a medical or a healthcare system perspective, we're often looking for sort of that one way to help fix or improve our patients. And really, in thinking or looking at sort of the wider picture, what we realize is there isn't kind of one way to solve a challenge for our larger community, and that we absolutely have to think about all of the determinants that really outside of typical medical and healthcare. In Riverside County, we know that housing is a particular challenge. Employment is a challenge. Looking at opportunities related to school and graduation rates, and how success in schools can really set you along the right trajectory versus high rates of school absenteeism or not being engaged in school being a marker or predictor for future challenges. And really, what I think we're pushing for, and what everybody's starting to talk about, is health is impacted by all of these other different factors, and so how can we think about health more holistically, and have this broader realization that in addition to prescribing medications or referring patients to specialists, having that discovery or that appreciation for someone's economic status, for their employment status, for what's happening within their family situation, whether or not they have social support, even their own attitudes and kind of beliefs about health and understanding. All of those things can have just as dramatic an impact on one's expected longevity, and sometimes even much greater than that. And that's actually what's led us into this larger state experiment in terms of reimbursement, or the CalAIM program, where all of a sudden we're now going to be reimbursing or piloting the reimbursement of non-traditional healthcare services like housing and housing navigation and rehabilitation and things that we actually believe can keep people out of the emergency room, the hospital, as well as skilled nursing facilities.
Thank you. Dr. Kumar, you deal with data every day in a big way, and data is really one of the important things in recognizing or identifying health disparities. And so I'm interested in hearing your perspective on how you think about identifying those, how you get the information to the clinicians so that they can be able to respond to any health disparities that might exist, and where you think the future is in this in data.
No, that's a great question, Dr. Vercio. And I think the first piece is to measure, meaning that collecting that information, at least the basic, what we call real and SOGI, meaning the race, ethnicity, and language, and the sexual orientation, gender identification information is a good start. And then you get into the economic status, the housing status, the transportation needs, and so on. And I think Dr. Leung alluded to measuring all the needs at the whole person level. Um, but then once you measure, by that I mean once you have the race identified or an ethnicity identified and so on, then you could almost, with any data set, when you start looking at outcomes or even process improvement, you can pull in that flavor of let's look at this initiative by this metric by race. Let's look at this by gender and so on. Even for very basic workflows, like when you look at cycle time spent in a clinic from the time a patient comes in to when they exit a clinic, what we've found is when we look at the differentiation by race, then we are able to see 1-2 minute differences, which may be statistically significant when you look at that large population where there is variation by race based on how much time a physician spent or how much time was spent in an encounter. Similarly, I think you had asked about medications and such. So, just as another example, when we look at our opioid utilization through our opioid stewardship, there are some differences that we see on how different races are prescribed opioid medications. And then there may be also be some provider level differentiations amongst that. But those are just some examples. Obviously, you can look at quality data. You can look at things like hemoglobin A1C for diabetes and look at non-Hispanic versus Hispanic. You can look at the quality of life years or the life expectancy, and then the things that feed in upstream even before that encounter that can impact the life expectancy, and then look at the differentiation by race or ethnicity. But I think race and ethnicity is maybe the starting step to address disparities and to look at equity. But if we collect that information consistently at every encounter and on every patient, some of the key demographics and social determinants, then the data analysis, I think, almost becomes automatic. And then, to your question about where we go from there, I think ideally you would want the outcomes to be agnostic of the patient's background or demographics or their social determinants. So that is the overarching goal. And we don't want to be in that same status quo with outcomes, 10 years from now or 20 years from now. So I think especially with some of the things that are upcoming with machine learning and the ability to be predictive and prescriptive, I think there's a lot of potential if we collect information and validate that and become better at that. The analysis and also the prescriptive pieces follow that automatically. I think the key challenge is making investments and cleaning up the data entry and the data collection. I think those go a long way in outcomes improvement from a data standpoint.
Okay, thank you. So I want to give you some time to kind of cover the information you had prepared on the task force and kind of the work that was done with that. So maybe if you want to go ahead and share your screen, Dr. Kumar, now, and then.
I wonder, Dr. Vercio, while Dr. Kumar pulls that up, can I just add a couple comments?
Oh, absolutely.
Yeah. So in thinking about kind of if measurement is that first piece or that first step, to discover where your disparities are, I think a second natural step, that we tend to take as healthcare organizations is we discover gaps, and then we try to sort of overcompensate for those gaps. So maybe we discover that a certain racial group or a certain subpopulation has a lower performance in a preventive care area, or a certain measurement area. And then we try to put more effort into outreaching to those individuals. That's sort of the typical thing that we do. And that's actually the same case as what we've seen with COVID. You know, if you look at sort of vaccination, even in California, there was goal setting based on sort of quartiles of socioeconomics across the state. And typically, you know, when we would discover that we had an under-vaccinated community, you know, the first tendency is you try to do more outreach and you try to make vaccine more accessible. So you place more vaccine sites in the area. But you know, I think this kind of it sort of speaks to maybe the third step that we have to consider. What's interesting is, even if you look at vaccination and you look at our communities with the lowest vaccination rates, you can put all sorts of mobile vaccine sites and fixed sites, and you can make the vaccine as available as possible, but that's not enough by itself. And so, you know, even as counties and states have taken that approach, they've still really struggled with their communities that have traditionally suffered from more disparities. And that's probably because our paradigm for how we're thinking about addressing that gap is overly, it's limited. You know, we're thinking that it's just a matter of access. It's just a matter of getting more vaccine to that location. It's just a matter of calling those people more, but it tends to be much more complicated than that. And once you start digging into the root cause, which I think is ultimately what we're trying to talk about with disparities, you know, getting to the root cause of what is impacting someone's, you know, health, you discover that it's, you know, education levels, it's transportation, you know, it's jobs where people are working two jobs, it's, you know, other scenarios that are also serving as barriers. So, you know, just making something accessible and available is no longer enough. So I'll pause right there, and I can see Dr. Kumar has this poster pulled up.
Thank you, Dr. Leung.
So, Dr. Vercio, you know, we recently submitted this poster for an initiative, and I thought it may be helpful to just walk through this, because this speaks to the work of the task force and strategies around where we see ourselves going in the coming years. You know, our task force is called Equity and Diversity Advocacy Task Force. And just a quick comment, you know, I think for those that may be on a pathway to creating working groups or task force, at least what we found was, I think it's very hard to put all the subjective into an objective, meaning that everyone is well-intentioned, but just trying to pull together all those ideas and come up with some key strategies. It took us almost about 6 months to get us there and get to a work plan. So the task force itself, like I mentioned before, has cross-representation from different areas of RUHS. And then our key strategies, which is the orange bucket or the orange balloon, are to educate and engage, and then data-driven improvement, and to help build partnerships. And then, you know, going back to the workshop from last year, this is where we came up with the opportunities. So as we got presenters from the workshop, we also ran some analytics on the presentation. And what we created was this word cloud, if you can see right in the middle of the bucket. What we found was there was a lot of cross-pollination, and there was a lot of overlap with focus on race and ethnicity, as you would expect, and then the economic needs. Those were some of the key areas where a lot of the initiatives were being focused on, and where disparities were being addressed. And we thought, you know, being a healthcare system, if we start out with the service lines and then the patient and their immediate community and so on, then we thought the next step is to look at disparities and then see who were impacted by those disparities, so the impacted clients. And the clients would mostly be patients and families and the population, but it could also be, in case of bias and so on, it could also be our own staff and our own workforce. And then we get into interventions, and then the last piece is cross-integration within RUHS, between the different verticals, but also beyond RUHS, in trying to build partnerships. And then RUHS, we are spread out all over. We have close to about 100 plus locations spread all over the county of Riverside. And then as we looked at the data, we also saw that there are some hubs like public health or the ED. There are also hubs around race and ethnicity as we tried to analyze what was presented through a PowerPoint and bring in some of the keywords and see where the connections are. The whole person health score, which we probably don't have time to get into it today, but it's a social determinant screening tool that Dr. Leung had devised, and we saw that as being a big hub in itself and trying to measure some of these disparities. And then some of the key findings were around communication, some of the healthcare gaps. Bias was something that stood out. And then some of the interventions which were already being tried by different departments, there was some alignment around, I talked about needing to measure or get that intake. I think that screening is very important. And then having some navigators such as case managers or very focused groups that can look at disparities and bridging those outcomes improvement initiatives. I think that's very key. And then the need to educate staff is also a key intervention. And I talked about the representation of the task force. We also have broad leadership support. We are very fortunate to have that buy-in right from the county leadership to our organizational leadership and so on. And just to walk you through one example would be that several areas articulated that one of the disparities was around bias and implicit bias and so on. And through the workshop, we also found out that public health was already invested in training their staff on implicit bias training. And through those conversations, and as well as through the task force, there was almost immediately a need. We identified certain core groups that would benefit from that implicit bias training. So that is one initiative where we started out with identifying a need. We found out a resource or one of the departments that was already ahead of the rest in trying to address that need for training. And now we are at the point where we are trying to get that resource available and that training available for other cohorts. And eventually, maybe within a year or two, we hope that anyone that is badged through RUHS, be it a staff member, an employee, or a contractor, goes through that training, irrespective of the role at RUHS. So that's just one example of where the task force serves as almost like a conductor, if you will, that collects information, does some analysis, and then builds partnerships. So I'll stop sharing there, Dr. Vercio.
Thank you, Dr. Kumar. And just wanted to make sure everybody is aware that we have an upcoming grand rounds that will be focused on this topic. And I don't know if you want to say anything about that, Dr. Kumar or Dr. Leung, and letting everybody know about that event.
Absolutely, Dr. Vercio and Dr. Leung, feel free to jump in. So we have a grand rounds that's focused on diversity, equity, and inclusion. We have three speakers. One would be the Chief Medical Officer of the Inland Empire Health Plan, Dr. Wada. And he'll be speaking to health plan level initiatives and strategies around disparity reduction and DEI efforts. And then we have Dr. Marcia Penny, who's the Deputy Director of Public Health for Equity, and she'll be talking to Riverside County level efforts around equity and disparity reduction and so on. And then we have Giovanna Giuliani, who's the Executive Director over the Safety Net Institute, which is a part of the California Association of Public Hospitals. and she'll be speaking to the state level initiatives, what would be coming with CalAIM, some of the needs to screen for social determinants, some of the disparity reduction efforts, and she'll be trying to present a broad stroke of everything that's happening at the state level and beyond. And we invite all of you. We will share the invite. The grand rounds are scheduled for Wednesday, the 20th of October, from noon to 1 p.m. So we look forward to all your attendance.
Thank you. I'll open it for anybody that might have any questions. So you can go ahead and raise your hand if you have any questions. Otherwise, thank you for joining us this afternoon, and hope you have a good rest of your week. And thank you to Dr. Kumar and Dr. Leung for being willing to open our Innovations webinar series for this year.
Thank you, Dr. Vercio.
Bye.